Please, I need your names in this Windows. Kirabian, I don't know who's he or she. Please exchange your name. Okay, everybody, let's start. I think it's enough time. We were expecting the rest of the group. Let me see, can you all watch my screen?
Yes.
Okay, perfect. As you know, this is our last theoretical session from Module 1. And well, you got these slides in the weekend, during the weekend, I mean, because I sent some homework about it. Let's see, let's check all the information, some meanings. And at the end, I'm gonna tell you some guidelines, some general information about the test for tomorrow night, okay? Today, we are going to make a fast review about hospitals, primary care, medical education, and the overseas doctor. Let's go. When we talk about hospitals, we all know that when we have to study, we decide to get into the medical school, we are going to stay into a hospital for a period of time. We're going to get in challenge, in practice. We are going to start reaching experience from students at the beginning and then as doctors, maybe. But when we go to the definition, we must consider this. The hospital is an institution that is built, staffed, and equipped for all the diagnosis of diseases, for the treatment, both medical and surgical, of the sick and the injured, and for their housing during this process. We all know this, but when we realize the definition, we must understand the objective of a hospital, right? This is a general view, just a general view about a hospital, a big one. I mean, when you have lots of services, and you might see there are changing in colors because of the attendance they offer, of the assistance they can bring to patients. This chart is just an example, of course, when you can see many different services, many different, the distribution of them, the place of them, and how patients are organized into. The ones who had experience working in a place like this, well, we all know that there are some labels like this with abbreviations, of course, just as an information slide. When with some directions, we can say, and all the services are divided according to this to the floor you are talking or the level you are at the moment, for giving that information and being ready to go from one place to another. Always the emergency department comes in red or in a different color because it has to be highlighted in order to help people to pay attention and ensure where you are going or where you stay. Let's check some important meanings. Take attention on this because these meanings are for the test, okay? They are in the text, into the homework, but check this and realize this, okay? Outpatients is the people who come to the hospital to attend a clinic or have a test or a treatment and then return home the same day. They don't stay at the hospital. They don't sleep there. Just go complete the process they are following and go back home while finishing. In that way, the assistance of outpatients is organized, of course, is following a role. It's not in an emergency attendance, an emergency assistance. It's not possible to realize that an outpatient is getting admitted because it was scheduled of that. No, it's not the way of working with outpatients. Just attend the clinic, assist to go to a medical appointment, have a test, receive treatment, and then go back home. That's the objective of the outpatients. The inpatients, on the other hand, is the people who stay in the hospital for 1 or more days in order to receive treatment. It's according to the situation. The patients, not the Romos, it's a typing mistake. I'm gonna correct it. They are called wards. Well, the rooms where they are called wards. In Spanish, cubículos, okay? Or not rooms, wards. In that order, you might consider this. Inpatients are always assisted into the hospital with the chief of service, the doctors that are in charge of the case, residents, students. We all know the process of this. Talking about patients that are getting admitted, that are going to become inpatients, we say patients can get into the hospital by 3 main ways. Usually, this organization is from USA and UK. For this text, I decided to use this information because it's clear and easy to understand. And it's similar in Latin America. We're going to check the difference. Patients that are admitted that are into or that are put on a waiting list. Patients with the treatment as they need. I mean, for example, a surgical procedure that is not in an emergency, a conventional surgical procedure, of course. In that order, they can wait, they turn, they date, go in the best way, I mean, with all the stuff they need, all the health, all the studies in the optimal situation, we could say. This waiting list could last around 2 or 3 months, is according to the situation. And it's the same in the different countries. I mean, USA, UK. You cannot say just that in Latin America we expect for being admitted for a conventional procedure for 3 or 4 months. It's the same in USA, maybe more time. Take it into consideration. The second way is a telephone admission. People who are acutely ill. These patients called on to the emergency service. The ambulance goes to evaluate the situation. The paramedic takes attention, consider all the considering what's going on. They bring the patient to the emergency room, and into the emergency room, these patients are getting admitted. But by phone, we have an idea what is going on. For example, a cerebrovascular disease, I don't know, something like that. An accident, a broken hip, well, we don't know. Then are patients that are seen, that are in assistance in the A&E department, accident and emergency department. The doctor on duty arrange the admissions if necessary. Of course, according to the situation, if the protocol is completed, patients are getting into the hospital. Okay, it's not by free. Why not in other places? Because of the health insurance they have to support. That's why protocols are the basis of this kind of job. It's similar in our countries, of course. In Latin America, we have the chance to wait for a conventional procedure or treatment by a list. Yes, it's possible. Telephone admissions, maybe it's different. Sometimes, well, we as Latins, we prefer to go by our, well, with our resources, by our own, I mean. Sometimes it's better to go that way than expecting for an ambulance because of the time. It's according to the situation and the country. And the emergency department, of course, has this capability. And doctors on duty have this decision, right? Of course, the doctor on duty has to get in contact with all of the specialists that the patient needs, and that's the way of working. The discharge is when, after treatment is completed, patients go back to their GP's care, is going back home, and then the general practitioner is going to make the following assistance at home. That's the way they work in primary care in other countries. For example, when patients get an appendectomy, stays at the hospital 2-3 days maybe, with the sutures is discharged at home, and the general practitioner with the nurse are going to check him at home, and they take out the sutures a week later. If they watch, there are some signs about complications on the skin, about wound infection, something that it's not going in a good way, they call the ambulance, they explain the situation, they support why the patient is going back to the hospital. Is again assisted on the department, emergency department, and they decide if he stays again at the hospital or is again discharged. That's the way they work. About health services, well, here in Bolivia, in so many countries, we have that service that provides medical treatment and care to the public or to a particular group. I mean, particular organizations that are prepared for assisting people. For example, here in Bolivia, we have the SUS, the Sistema Único de Salud, universal y gratuito. Well, that's a dream, but that's the way we work here. And we have so many private health insurance, for example, some organizations that are evaluating the private health insurance, some private clinicals. So let's consider this just as an information. Medical treatment really needs to be supported by extra institutions in order to give the best attendance, the best assistance. About healthcare systems in general in many countries, we could consider the organization and the structure in some other places. Just for making a comparison, I mean, if you go to USA, you need your health insurance number. Without the number, it's not possible to get into a hospital and being admitted. If you decide to pay it, of course, it's extremely expensive. But going to the healthcare system, this organization, this structure, you have 3 ways to receive the assistance. The popular healthcare system or subsystem is supported by the government, of course, with the basic things, medication and stuff, because it's by government just. This part, yeah, this subsystem is not for research, it's for providing assistance to immigrants or someone that is without all the documents. I mean, the green card or residency. The subsystem, the complementary or alternative healthcare subsystem, is considering all the branches that work with medicine, but are not just medicine. I mean, sports, programs, specific programs for bringing support. They don't develop research, but they have more resources because they are alternative. It's a different way of working. This subsystem is for people with a green card, for example. You really need to be with all of the documentation in there for getting the access to this part. And the basis of this, the scientific healthcare subsystem. And the scientific one, it's divided into branches. So the personal healthcare sector for healthcare providers just, and the population healthcare sector for patients, of course. The personal healthcare sector, of course, we have a different assistance. We have a plus because we are a part of the team. We receive different facilities, we can say, according how the really needs we have, and receiving the assistance in the place we work. That's why if you are a healthcare provider, you have the chance to insurance in the place you are moving or working. It's a plus, it's easier. Of course, you are with your green card, everything in order. The population healthcare sector, that's the branch when we can develop research. That's the branch that receives the major quantity of money, we can say, of resources, because we have to be divided in 3 branches again. The public health agencies for local, state, and federal, it's according to the state you are living, working, and have your health insurance number. You have the private health agencies when you go and pay and make an inversion on your health because it's because you want to be there and you have your own number. And the voluntary health agencies. This voluntary is supported by institutions that give the resources. Of course, here you found lots of poor people, but that's the way they work. These 3 branches are the ones that are supporting the healthcare system for research, as I was telling you. And of course, they have all the necessities covered, we can say. Of course, following the protocols, we can get into detail and consider all the situation. Let's make a comparison. This is well, let's divide it into pictures, but this was just an infogram. It's coming from the World Health Organization, showing these statistics. They are talking about overview, about hospitals, about health insurance, about travel or international health insurance. Very important. According to this information, according to numbers, to statistics, we can understand why the United States is one of the strongest healthcare systems that is at this point, like an example for the rest of the world, because of the number of hospitals, number of medical staff, nursing and staff, how they support research, how they follow protocols and make processes for evaluating continuously and improving their services. Read it as an introduction for the module 2, because we are going to talk like this with numbers from Monday ahead. So consider this just as an extra slide for information. Going ahead. Well, in Bolivia, yeah, of course, because I live in Bolivia, we have the healthcare organization. That sounds good when you check the theory, because it's not very complicated to understand it. We have the national capability, we could say, when the Ministry of Health is the basis of this. The national responsibilities support the departmental and the local and municipal according to the activities are being developed, not for everything. The Ministry of Health supports the SAFSI or MISALUD teams, general practitioners and teams that work in the local or municipal level for developing primary care. It's from the ministry. Also, the ministry can support the Department Health Service, the SEDES, according to the activity and program that, as at the moment, for example, the tuberculosis program that At the same time, is supported by the World Health Organization, and they directly go to primary care. When we go to the departmental responsibilities, they are supporting the government actions. I mean, it's independent one to other. So they have health networks. They must support the department health service, the sedes from every department, and they go to the municipal social councils. I mean, these councils and the sedes are supposed to work together according to the activity, not for everything. So it's, well, it's like that phrase, divide your strength and everything is going to be better. That's the idea, to reorganize the responsibilities, and then you talk about your numbers in order you really need. So you have the health networks, the municipal government, and the primary care service supported by the Ministry of Health. Following this, it's supposed that we should have one doctor every 2,000 people around, but it's just a dream. It's not possible. We don't have enough doctors to make it true. Please read this information, consider as an extra slide just. This is just a general view of this. And now we have this chart. Again, the World Health Organization giving us some numbers, some statistics that support how our work is being developed in Bolivia specifically. Of course, we are in this place. It's not the best of, well, I really feel ashamed about it, but it happens. This ranking is considered, well, I think it's, let me remind, it's from 1, 2, 3, around 5 years ago, I took this information. Let me check if we have a new one. I'm going to exchange it, and in module 2, we have the chance to talk about it, but let's see. There are 0.47, almost all, half doctor, half physician per 1,000 people. So let's consider the difference. Read this, consider this just for checking the information. Considering primary care important meanings. Well, we have lots of terms that we were checking during the module 1. For example, the general practitioner, of course, the GP, we all know, the best guys, yeah, the primary care responsible, right? Then we get this term, to make a referral or to refer a patient. If a patient needs a specialist care, is sent to a consultant in secondary care. Okay, to make a referral, of course, is following some rules. Of course, we need to consider how to prepare this letter because it's a letter, and we're going to do it in module 2, so don't worry about it now. According to that, making a referral is because, well, it's supported by a protocol, of course. The same every place all over the world. You don't have the chance to send to the consultant, to the specialist, if you don't have a diagnosis or suspect a diagnosis that really needs that kind of assistance. Then you have the home visits. You have the chance, well, to visit a patient at home as an appointment. Of course, it's an appointment because you have a schedule, you have a specific date and time for going there and then checking the situation. They are made when patients are housebound, I mean, unable to leave their home or are too ill, or there is no way to move because of the health situation, not just too ill. If the patient is living with a wheelchair and there is no one who could help the patient to move on, well, he asked for a home visit, and following the appointment, following the role, it's possible to visit him and evaluate the situation. Usually home visits are prepared for making, well, for following the process in chronic and chronic diseases, chronic situations, for example, hypertension, diabetes, considering that every month they really need to receive medication. So doctors go, check the patient, leave the medical prescription, and then the patient has to pick up from the drugstore, from the pharmacy, the medication, and that's all. The objective of this is not to make crowded the hospitals or the healthcare system. Another meaning, the out-of-hours treatment, OOH. This is just for Europe, to UK, France, and Italy, if I'm not wrong. This is a specific consultant room when patients are provided by the local primary care trust, which organizes shifts of GPs. I mean, there is a GP in that consultant room that is just waiting for people to go to pick up the medical prescription. That's all. You go to, in your turn, in your schedule, you go in the doctor, in the shift of the doctor that is working with your case, you pick up your medical recipe and then go to the pharmacy, and that's all, just for receiving medication, okay? Maybe if there's an acute situation that is not so difficult to solve, you can receive the treatment in this place. It's possible to receive it, but it's for a very short period of time. And the locum, covering the shift of a grave someone is absent. I mean, the locum is a doctor who has enough experience to cover shifts in many different places in the healthcare system, not just into the hospital. The locum, the doctor that has this charge, has the capability to go to cover a shift into the emergency room, for example, or into a specific service, or into the out-of-hours treatment. It's according to the place that they need this support. The locum organizes the shift. Maybe one doctor is with an emergency, who knows, but there is no one that is going to cover this space. So the locum has to go there and work there. Of course, it's hard, but it's possible to make it, right? With all the specific preparation experience, it's a good way to work, I think. Then we have the district nurses. Let's consider her because it's very important, their job. They're the ones that usually visit temporarily housebound patients, such as discharged hospital patients for not complicated procedures. I mean, taking a biopsy, making the excision of a cyst. Well, I don't know. But nurses go, check the wounds, exchange dressings. Well, it's nice. It's a good job. Go on following. If they realize maybe a red flag about complications, they have the capability to send the patient to the primary care service, to the healthcare assistants, to check the situation. If it's necessary, the general practitioner that is in that healthcare center refers the patient to the hospital. As you can see, it's a chain that they are following in order to improve the healthcare system. For changing dressings, the district nurses go home, check the patient, such as ulcer dressings. We all know, we all have the chance to treat a skin lesion like this, I think. So it's possible to go home to make the procedure there without moving the patient too much. It's better, right? It's usually done by the district nurses. Here in Latin America, well, we don't have that way of working. In Cuba, it's just the only place we have the chance. But it's developed by a general practitioner, not by the district nurse. It's different. Then we have the midwife. We were talking about this meaning in the previous class. Training the staff who take care on antenatal patients. Well, actually, the midwife is that nurse that is prepared for following all the pregnancy. And if the patient is denying going to the hospital and wants that nurse assists the parturition, well, she's prepared to do that, but it's not the optimal situation. It's not the best. It could happen in rural areas when midwives are still working through the time, and well, there's no way to change it because of cultural reasons, right? And now we have the health visitors, again, nurses that are trained staff that visit families to carry out checkups of young children. I mean, healthy young children, particularly under 5, to make sure they are healthy, right? As you are checking this. For healthy children under 5, the health visitors goes with all the material that she needs or he needs and evaluates weight, evaluates growing, evaluates the neurological development, all the structures. If there is something that is calling attention because the kid is not gaining enough weight, they have the capability to refer this kid to the pediatrician, to the general practitioner, or to the pediatrician according to the situation. If, for example, that's the way with health visitors that work in Cuba. For example, if you have an appointment and you are not there, the health visitor has the obligation to give this information that mother was not there. Instead, she knew there was an appointment. So the government gets into and starts following, making the care procedure, we can say, for the kids' well-being, right? That's the best way with the health visitor to complete the vaccine programs, to complete the healthcare programs that are prepared at that ages. Let's go ahead. Okay, about medical education, the general view. We have the undergraduate education. We all know about it. We all had the experience of this. It's usually 5 years at medical school, the section of university responsible for medical education. I mean, you are in a university. That university has a branch for human medicine. Usually 5 years, and while you finish these 5 years, you become, well, in UK, in Europe, a Bachelor of Medicine or Bachelor of Surgery. I mean, going to Spanish. Here in Bolivia, we say médico cirujano, for example. That's the same Bachelor of Surgery. You are a general practitioner, but the way in a country is called Bachelor of Surgery, but you are a general practitioner. Why of surgery? Because you have that capability just. It's a 5-year undergraduate medical degree course. Most of your learning takes place in the small groups. And you have all of these divisions. This is for UK and USA. The core, 1 to 3 years. When you have the option to get in a program on clinical and scientific topics, presenting problem-based learning. According to clinical situation, you are catching the theoretical information, I mean. It's nice. You start checking clinical cases, real situations, and you realize how anatomical structures are related to that. Well, it's different, a different way to do, because you're preparing your medical thoughts that way. Then you become, or you go to the selected modules, of course, when you have the chance to allow, well, they allow you to choose from a menu of subjects in order to prepare for an overseas selective. I mean, you choose the branches you want to practice at the beginning. Then you have the vocational studies and clinical skills. This program prepares you for the clinical skills required for contact with patients from year 1 through periods of practical training among hospital departments or general practice. These vocational studies are optative in so many countries in Europe. In Cuba, you go to check patients from the first year with the GP, with the general practitioner, as a part of the program, medical program. Here in Bolivia, of course, it's different. It's not possible to make it. It's another way to do it just. Well, let's consider this. Then we have the clinical attachments, the ones that you have to study. You have to be there and suffer there. Yeah, it's just for an expression. The clinical attachments for years 4 and 5, usually. A series of 4-week clinical attachments in internal medicine, surgery, psychological medicine, pediatrics, obstetrics, and gynecology, and general practice. You go to all of these branches in order to get enough experience, and according to that, and following your scores, you have the chance to develop your specialty when the moment is arriving, right? When you finish these 5 years, you have to complete the 6th one, the rotating internship. I mean, that year that we all loved and hated at the same time, because, well, you have the chance to practice with all the theoretical and practical activities you were learning. You show and you develop your capabilities, and, well, you start learning how to get in contact with patients. In almost all over the world, the rotating internship is 1 full year getting into internal medicine, surgery, obstetrics and gynecology, pediatrics, and the social service or rural service. It changes according to the place. For example, in Cuba, I tell you because that was my medical school. In Cuba, you were rotating the 6th year, the full one in the 4 specialties I told you now, and as applies to the emergency department. But when you became an intern the last year, you had the chance to work by your own, just showing what you know, showing your best, thinking by yourself, talking by yourself, preparing your treatment by your own. That's a very good activity because you develop all your skills. And you lose the fear about asking questions to a professor maybe, or giving orders by yourself. Here in Bolivia is different. In the routine internship, the intern has to be with the doctor, and the doctor is teaching and teaching and talking. And it's a different way of working, I mean. In the social service, the rural information, I mean, you have the chance to develop this with patients in lands. So it's different, right? This is just a joke, how you started the daily activity, about your period of time, how days are going on. Just a joke. Okay. When you become a postgraduate, you have to make in your country your registration. I mean, we were talking about it, a specific number that allows you to work as a doctor, of course, and usually requires the development in rural areas at the beginning. In many countries in Europe, you become with your register, and because it's a requirement for getting into the residency program, you have to go to the rural area and work 1 or 2 years. Work there, not completing the internship. In Cuba, you have a full internship with the social service, the rural service. And according to the specialty you choose, there could be longer for 1 or 2 years. In Bolivia, the rural, the social service in the rural areas are for 3 months. And you go as a student. You don't have the real responsibility of this. Develop your research, all the job that is prepared for you, and that's all. Just 1 class, 1 extra class. In some other countries, could be 6 months, and some other ones could be 3 months. It's according to the place you are living now. But in Europe, you have to complete with register with all the responsibilities that period of time, and then you can get the residency course. About continuing professional development, well, of course, is the process by which health professionals keeps updated to meet the needs of patients, but it's according the branch you decide to work on. In my case, I got all of these courses done. I got all of these programs developed, and well, it's because I love emergency medicine. I love to stay there, to run in math. That's why I'm hyperactive, so I really need to be in that stress. But you have the chance to look for what you really like during the career, and if you feel comfortable there, do it. Do it, but continue studying. When you finish the medical school, I was talking about it with one of your classmates yesterday. When you finish the medical school, you realize what you are good at or what you like to do. So do your best in that branch. It's not possible to do your best in everything. It's not possible that everything is made for you. We always go to a specific branch. So in my case, for emergency, in other cases could be obstetrics, in other cases, I don't know, aesthetics, in other places, traumatology just. We have too much information to check, too many societies to get into, too many opportunities now because of the internet to get informed. So I encourage you to continue, to focus and continue. Going to foundation programs. Well, that's a nice way to get into the residency courses. It's for UK and USA. Both of them have similar ways to do it. The foundation program is a 2-year training program which forms the bridge between university and level study and medical school. I mean the residency course. These foundations are institutions that are paying for you. They pay you a salary, they pay your month into the hospital for being prepared. And according to your experience, your job, well, all the good points, we can say, you reach, you can get the residency course. It's not by free, of course. You have to make your best effort to show that you really deserve that space, that opportunity to study. It consists of a series of placements, each one lasting 4 months, according to the place, which allow a junior doctor, a trainee, to sample different specialties. For example, pediatrics. You have the foundation 1 year, the 1 year trainee, and the foundation 2 year, the 2 year trainee, just for information, okay? When you become a trainee, each one has an educational supervisor. This supervisor ensures that more senior doctors, that older doctors, that professors, deliver training in different ways, including clinical and educational supervision. This educational supervisor is the one who's giving the assistance, who's checking, is better to say in that way, who's checking that you as a trainee receive the medical and the clinical training. To progress, of course, the trainee has to demonstrate it, a range of clinical competencies. They are assessed through observation in the workplace. They are objectives to follow. If you don't reach all the objectives, you're out of the program, out of the foundation, out of the capability in that year to become a resident. And of course, there is a record. Following that record, you might receive a second chance if you fail it, but if you're good at that, it's better because you have the chance to go to a better place of studying and living. This is just an example. It's from Australia, that when they have a similar program, when you have the first year trainee, a second year trainee, and all of these services, they go and practice with all of this. F1 and F2 have the chance to stay in extra services for practicing, for showing their capabilities. And of course, when they complete this rotation specialties, they have the chance to become a second year. In the second year trainee, they have the chance to go to more specific specialties, for example, ophthalmology or pediatric surgery, or the emergency department. Not everybody's going there. You have to be in the second year. You can see here and here, second year for accident or acute and emergency department. Anesthesia, well, GOSO general is because GOSO is the island when this program is developed. And the general practitioner service. To become a good general practitioner in many other countries, it's not easy as in our countries, of course. To become a good one with all of the validation, all of the capabilities that real general practice brings, you really need to be up to date. You really need to be focused, right? Well, about people in medical education, is just for information. There are the meanings what everyone does into the program, the foundation program. You could read it just as an extra slide, as extra information. The tutor, well, is the one that is, in some cases, the postgraduate student who leads tutorials, the one that is teaching to medical students from the 1 to the 5th year. The demonstrator is the one that demonstrates how to do a specific capability, that shows how to develop that capabilities. I mean, in this case, we can talk about dissection, about a corpse. Okay. The lecturer or the senior lecturer is the one who's teaching students how to understand research and the responsibilities into research activities. It's not for everybody. You have to be prepared for becoming a lecturer, because there are steps for research and we all know the scientific method. But in medicine, it has some differences that we must consider. A professor is the doctor that has the capability to teach into a particular discipline, for example, obstetrics. In that way, has the enough clinical experience, clinical training, has the capability, has the upgrade to teach. The college tutor is the responsible for delivering the college training program, is the one who prepares the program for getting into the residency programs. The clinical trainer, of course, the one who's giving training during the first and second year of trainee, right? And the educational supervisor, well, as I was telling you, the one that is supervising the trainees period. The supervisor is the one who realizes, who checks the progress, and the one who is giving the opportunity, we can say, to get into the residency course. That's why the educational supervisor is so important. Some medical qualifications are all of this. When you have the chance through the time to receive these diplomas, these recognitions, you can say. So just as an extra information, is from the United Kingdom. So check this, just as a general view. I decided to send it because, well, sometimes we can see a fellow of the Royal College of Surgeons. I mean, it's a professor into this College of Surgeons. It's not the same in all over the world, but the meanings could be similar. To become a member, for example, of the Royal College of Physicians really needs to support on years on patients attended, on patient assistance, on many requirements that sometimes are out of hands. To become a fellow in surgery, for example, or fellow of the Royal College of Surgeons of England, you need a specific number of specific surgeries that you could develop, because with that support, you show that you're prepared to become a fellow. So it's not as easy as it looks. The doctor of medicine, the MD or DM, both of them are correct, is, well, when you become a general practitioner, you make your residency course in internal medicine, and then you have some other upgrades to reach, and then you become a doctor. It's a great way to do it. Talking about the overseas doctor, well, it's just for UK at this point, showing you how to go step by step through the time and checking all the situations that are around this. For example, types of registration in UK. The provisional registration are for doctors who have qualified from medical school in UK just for working in UK, not other place. The full registration, doctors who have completed the year's clinical training. Well, they finish the 5 years, the social service, the rural area job, and then get the full registration. This full registration allows you to work in so many places, some different countries. The limited registration is for international medical graduates who have not completed the equivalence of year clinical training in UK. I mean, if you, for example, I finished in Cuba, so I have the chance to go to UK to make valid my title, my medicine title there, but it's limited because I have to complete this year of training. While completing this, I get the full one. With this full one, I can go to so many places. The specialist registration, of course, when you get the residency course completed, you get as a specialist, okay? And the PLAB, well, the PLAB, it's just a professional and linguistic assessment board test. It's ensuring that you have enough practice in UK English for working in a hospital. It's a very hard test, but it's possible to make it. Just reading and practicing, okay? And keep calm and carry on. You know, as you could see, it was a very administrative activity, just for information, just for taking into account this vocabulary that could be called as an introduction to Model 2. Please fill the pool, and that's all. As you are finishing this, I'm going to take attendance, okay? Okay. I need one more, and that's all. The ones who feel it can leave the Zoom, that's okay. Perfect. The ones who told me done, you are free. Yeah, you can leave. Keep on reading, and if there is anything to talk, please send me a message by WhatsApp. Can you all of you watch the pool?
Thank you, teacher.
Okay, you're welcome. See you tomorrow during the test, okay? I'm gonna send to the WhatsApp group all the information we need for the final test.
Bye.
Bye, Maria. See you tomorrow.
See you tomorrow.
See you. So, Natalie. Bye, Natalie. I got your message. Okay. So everything is done. The class is over. Bye-bye. Let's finish with this. Let's finish him.